So there was a planning committee for this group, and I wanted to thank the fellow members of the planning committee. They gave some great input and help in helping us to determine what would be best to speak with you about and how we might engage you best. So Patrick Burke, thank you. Chris Blasky, thank you. And Brandon Cole, who couldn't be here today, thank you very much. My name is Linda Cohen. I'm an attorney. I do healthcare law, and I work very closely with OneCare Vermont. I'm here with OneCare Vermont board members and the chief medical officer. So Norm Ward, this is the chief medical officer of OneCare. He's also a practicing family physician. And Steve Leffler is on the board, the chair of the Population Health Strategy Committee. He is the clinical and population health and quality officer for the University of Vermont Health Network and a practicing emergency room physician. So there is a login or a site there to go to the chat room, because what the three of us have encountered is that we feel like we kind of have this dream state of alignment and coordination in clinical, regulatory, and legal opportunities. And we miss you guys. And we want to hear your ideas about how we can best take advantage of the opportunities that we have, because we're tremendously excited by them. So what we'll do is I'll briefly talk about some what's going on in Vermont from a payment perspective. Norm and Steve will talk about the clinical model and how OneCare is organized, and then I'll talk about some barriers that have been removed for us by fraud and abuse waivers and some ideas that we have. And any time that someone has input, please, Ellen will be moderating the chat room and she can interrupt us. We've basically said that if we wind up just interacting with the audience and hearing ideas, that would be fantastic for us. So not to worry about interrupting us in the least. Okay, so can we start our PowerPoint? Oh, I'm so sorry. I also wanted to add that what the state that we're in was not achieved like with a snap, right? There was a ton of hard work that went into achieving all of the alignments that are here, from faculty members who conceived of accountable care organizations and helped with policy and developing them, to some of our fellow students who were engaged actively on behalf of the state in negotiating some of these arrangements and in continuing to regulate the arrangements, to all of the stakeholders in Vermont who had meetings for years to figure out how best to align the incentives and to best create a program. So thank you to everybody who provided the foundation for us to be able to launch from and try to do some of this exciting work. So there's the chat room again. Okay, so part of why we're so excited is that we feel like there are a unique set of alignments for innovation in Vermont. First of all, we have multi-stakeholder involvement. You'll hear later in a little more detail, but OneCare's board is comprised of the full continuum of care, representatives of the full continuum of care, from physicians, hospitals, designated mental health agencies, home health agencies, skilled nursing facilities. So we've all got everybody in the same boat rowing together, which is unusual, and we want to make sure that we can do the best we can with it. We have regulatory and program uniformity. The federal and state government have aligned some of the regulations and given us the same kind of waiver opportunities, which means that we can do one path of care. You know, it's not so much when you check in who's your insurer, but hopefully we'll be able to just do a single path of care for things. We have a well-developed clinical continuum of care and models of care within the organization, and you'll hear more about that. We have robust and coordinated information technology, which is really exciting. And we have this ability to test new models of care and payment at the micro level through fraud and abuse waivers. So we're operating under this all-payer model. So basically, what is the all-payer model? The all-payer model is an agreement between the federal government and the Vermont state government that basically says we're going to hold down the rate of spending or increase in spending in healthcare by giving all of the Medicare money to Vermont, and the Medicaid money will set into this pool, and it comes down to the ACO, who then pays providers. So the goals of that all-payer model are to limit the healthcare cost growth to 3.5% over the totality of the 5 years of the model. So if 1 year is 3.6 and another is 2, success. increase access to primary care, and improve health outcomes. Some of the measures in the all-payer model are related to suicide prevention, substance abuse deaths, and chronic disease. The way that we're implementing the all-payer model is through regulated accountable care organizations. OneCare just was certified by the state of Vermont as an accountable care organization, and will now be able to accept payments through that all-payer model because it was certified to do that. We have alignment across payers. We're running similar models for Medicare, Medicaid, and commercial. The goal is to get about 80% of Vermont's population into this one model, again, testing what happens if we're all in a single stream, and to increase coordination of care. So there's a contract between the state and the federal government. We also have aligned program agreements. The Next Generation program agreement, I'm not sure how much people know about that, but basically providers are at risk for the cost of care. So we have hospitals operating under fixed budgets. And when I say hospital, I mean the hospital and everybody who bills under the hospital's tax identification number. So that includes employed physicians. And then we have a set of agreements between the ACO and providers to accomplish the model. So this is OneCare Vermont. The Board of Managers is responsible for the organization. Again, we have hospital designees. Under the accountable care organization rules, you need to have 75% of your board control or seated by participants. So this is provider-led change, which is exactly why we want to hear so much from you, because that's the input that we need to really make this successful. So we have Clinical and Quality Advisory Committee that sets the clinical direction. The Population Health Committee is an overall strategy organization. We have a Risk Strategy Committee. That's for hospitals that are not yet at risk but thinking about being at risk, so that they can come in and understand and participate in some of the discussions, because it's a big decision to go at risk for the total cost of care for a hospital. So there's been a lot of acclimation ahead of coming into Next Gen, basically to say our training wheels are off, right? So we're riding the bike, we're not in shared savings anymore, our training wheels are off, and we've got to get down the road to holding down costs in order to be successful. So OneCare was founded in 2012. I mentioned that it has a representative governance by provider type. Initially, it offered shared savings programs, and the shared savings were equally shared between primary care and hospitals. We did achieve some success in Medicaid with achieving shared savings, but not yet in other programs. We are running the same kind of program across Medicare, Medicaid, and commercial. We have one dominant commercial payer in Vermont, Blue Cross of Vermont, and that's very helpful because there's not as much need to align for different commercial insurers. And we're building attribution. The way we build attribution is having primary care physicians in the OneCare network, because they are the attributing providers. We have a statewide network. All types of hospitals include FQHCs, independent physicians, a little bit different in perspective and practice needs than hospital-affiliated physicians or employed physicians, nursing homes, designated agencies, and other providers. There are 7 risk communities in Vermont. So if you look, we have a pretty good geographical spread in the state, and also Dartmouth is a critical partner in this. There are 2 members of OneCare, and they are the University of Vermont Health Medical Center and Dartmouth-Hitchcock. In order to participate as a provider in OneCare, you need to have your local hospital participating, and that's because of the coordination of care and also because of the assumption of risk. So the initial model here is that the hospitals are assuming the risk for their local communities so that they have a strong incentive to help in the coordination, and candidly, that's where the financial ability to bear the risk sits. There's also very active regulation in Vermont of hospital budgets, and so there's a lot of tie-in about how all of this works, because we have a regulator called the Green Mountain Care Board who has oversight of commercial insurance rates, hospital budgets, and accountable care organizations, and other aspects of healthcare policy, certificate of need. But there's one place that's kind of looking at it all and tying it together, which is another pretty unusual factor. So for 2018, where there are 3 risk programs that are running: Medicare, which is a modified Next Gen. So part of the agreement between the federal government and the state was for the state to be able to set some of the financial targets for the Medicare Next Gen, which is a big concession on the federal part. And it's very helpful for us to be working with, because we have a relationship with the federal regulator and with the state regulator, but we're really able to adapt the model for Vermont and what's going to make sense for Vermont. And on the commercial side, we have a 2-sided risk contract with Blue Cross Blue Shield, and these are the different sharing. So the model of how much you're at risk and how much you share if you achieve savings, or how much you pay back if you don't achieve savings, is flexible between the programs, but it's a pretty standard model. Okay. So the hospital, is that you? Yeah, that's Steve.
Just keep going if you want.
No, that's all right.
Thanks, Linda. So I thought I would just quickly summarize again exactly what we're doing, because I think it's helpful to hear it. And you hear the lawyer view, I'll give you the doctor's view. So the state of Vermont is in a 5-year experiment with the federal government, with CMS, really around 3 areas. So the first area is, can we control the rate of healthcare spending growth to 3.5% over 5 years? So that's a big target. And you heard some of the levers. We'll talk a lot more about what the options are in there. Number 2, and I actually think where a lot of the work's happening right now, is can you get 70% of commercially insured Vermonters and 90% of all Vermonters with Medicare into the program. So about 80% of overall Vermonters need to be in the program over the 5 years for that component to be deemed successful. And what that really means is bringing in providers. The way lives come into the program is through their attributed providers, bringing in primary care. So that means the model has to make sense, be appealing, and providers have to feel like it's going to serve their patients well, and it's going to serve them well in their livelihood. So a really big issue there is, can we bring the lives in? And there's a lot of work going on that right now. And then part 3, and I would say most importantly, does this model improve the health of the Vermonters that we serve? And you'll hear some things that were put into this model to try to see if over the 5 years in a new payment strategy, a value-based world, have we improved access to primary care, improved access to mental health, driven down the suicide rate, things like that. So if you think about it as a 5-year experiment signed by the state of Vermont and the federal government, OneCare is an ACO that is approved to deliver on the payment strategy of the model, but the model is really a Vermont CMS program. I just think it's helpful to hear it that way.
Can we, just a couple questions from the, as you go through with your remarks, and one is, can you talk about, as you go through, whether Vermont's small size is actually an asset or a liability, or perhaps both in this? And also, you mentioned the global budget and the 3.5% growth, but it's important to put that in context with what has it been. So as you talk about that, if you can address that.
I'll take the first one, the first question to start with. And so I actually think it's a huge advantage to be small, because there's only 14 hospitals in the state. We all mostly know each other. The providers have a good relationship. It's very common. I would say most of the providers in the state have some kind of knowledge of each other. And Norm and I have done a lot of chicken dinners over this winter explaining this program to providers, and most of them we have some relationship with. The flip side of that is Vermont is really small, and so like our regulators are in the room this morning. Robin, yes. So I have to be really careful what I say. No, I'm just kidding. But, so I mean, there's good and bad, right? But I do think on the whole, Vermont was a chunk that I think CMS thought was attainable. 650,000 people, 14 hospitals, about 2,000 providers. If you can't do it in that type of scale, what are the chances of doing it bigger? And I will tell you, even at a small scale like that, it's still very hard to get all the providers to row in the same direction. People in the state have chosen to have very independent practices, chosen not to be at the academic medical center, chose to be in a community hospital, and working through those issues, I think, is a really big deal. I will tell you that in terms of spending, it's been all over the place. Over the last couple of years, the spending has trended under 3%, but as recently as 4 or 5 years ago, it was 6% plus. I've seen some projections that say because Vermont is becoming a very old state, there's an expectation our spending is really going to increase quickly. So I think 3.5% is a realistic, achievable goal. Not easy, but I think we can do it with the right pieces in place. You guys want to add to that?
No.
All right. Sounds good. So, as we said, this is a prospective payment model for Medicaid, Medicare, and commercial insurance. And in this model, the hospitals bear all the risk, okay? We couldn't figure out a way, and we didn't think it made sense to go to primary care offices and say, look, you're small, you have no margin, you're basically living on the edge, but we're going to put you at risk. I mean, we could put them out of business in 1 year. The way I think about this is, in the state of Vermont last year, the hospital's total margin for all 14 hospitals was around $60 million, close to that. And this model puts about $20 million at risk, upside or downside. So about a third of the margin of the hospitals, they are saying, we're willing to put that in to try and change the care model. That's the way I think about it, about the amount of risk. And Linda already said this, so we've had providers come to us and say, we want to participate, but the way it's set up, the hospital bears the risk, and so for providers to be in, but their hospital not be in, doesn't really make sense. So you can see on that map, there's a couple big hospitals from the state that aren't in yet, for good reasons. Rutland's a good example. And some of their providers would like to be in the model, but for the provider to be in with no governor from the hospital is very tricky, so we haven't done that. There is significant primary care support reform. If you really look at how the model works, dollars are flowing from the hospital operating budgets into OneCare. There's some dollars that are coming in from other programs, from Blue Cross, from Medicaid, and so on, and those dollars really flow back out to primary care to give enhanced primary care, wraparound service, and so on. So it's really a model where it's shifting dollars away from the chief operating officers and the CFOs of the hospitals and out into primary care. Someone already asked me, why would the hospital do that? That seems insane. Well, the belief is under capitation, if you can keep people in lower cost settings, if you can have them get more primary care visits, you'll drive down the cost to the hospital, and that's how the hospital will make its margin. If 80% of Vermonters are in, over 5 years, the hospitals have to look different. So we firmly believe we had to, and it's important to include home health, designated agencies, substance abuse has to be in, area agencies on aging, and it's really working on population health management. So RISE Vermont is a good example of a proactive way to try and keep people healthier by engaging with their communities. And you'll see the rest of these and the other ones, the different quadrants. So we'll move to the next slide, which really gives an example. I guess I'll move to the next slide. Of different categories. So if you think about this 4 quadrants, on the upper left for you, about 44% of the attributed population is healthy and well. Okay, this is that you think about your young 27-year-old person like my son. He needs to wear a seatbelt, get vaccinated, not speed, and wear a helmet. Really, that's what he needs to do, right? And so it's how do you engage with them, how do you get them on the right path, and RISE Vermont, keeping them healthy, helping them not need to go on medicines for things is really the focus there. The next category up is 40% of the population. That's someone who might have simple hypertension. So get them on medicine, make sure they're compliant, do good screening to make sure they're not getting renal disease, stuff like that. Not much of the spending in those upper 2, but you have to do good work up there so over time we're keeping people healthier. That's really the long-term success or failure of this model. If you get down to the lower right quadrant, 10% of the population, this is people who now begin to need chronic health care. This is someone who's getting their cardiac cath. This is someone who now has maybe renal insufficiency. They start to really consume resources. They're expensive, they need a lot of visits, they need good coordination of care. If you look at category 3, which is lower right, and category 4, which is lower left, that's 16% of the lives in the model, but over 40% of the spending. 89% of them have a chronic medical condition, and 67% have a mental health condition. So a sick population. Interestingly, we did a little looking at group 4, because some people said it's only 6% of the population. Maybe you should really put resources there. But in that population, there's a couple different groups. There are some people who are have renal failure and are on dialysis, and they're going to be expensive. You can coordinate them. Then there's people that jump down in there because they have a life-threatening accident, and they're really sick, and they're in the unit, and they have 3 months of huge surgeries and stuff, but then they kind of move back out. Or there are people who have, terminal cancer or something, and they get in there, and I'll say they move back out in a different way. But probably a lot of the opportunity here is in that category 3, to really go aggressively manage that population. So some of the activities we're doing. So these are some of the ways the model is measuring and seeing if we can keep people healthier. So it's going to measure the percent of adults can identify a primary care provider. So we want to have a good, strong primary care connection for Medicaid patients and their attribution, whether with a primary care or ideally not with a specialist. So there's work going on there. And we're trying to make sure primary care, through payment reform, has strong, viable practices. Vermont has an issue with suicide, mental health crisis, right? So can we embed mental health in primary care, in senior living, in new models, possibly with telemedicine, things like that, to make sure that all Vermonters who need it had good, immediate, or quick access to mental health, and then really expand data for risk stratification. Understand the statewide prevalence of chronic illnesses such as COPD, hypertension, and diabetes, and make sure that we know who has it and that we're proactively managing this population as efficiently as possible. And you can see here there's some examples of what we're doing on those type things. And we're doing a lot of work with community collaboratives to promote local primary prevention. RISE Vermont, 3-4-50s, the state program, which they tie together pretty nicely, the Vermont Quit Line to help people stop smoking.
Could I just interject that the scariest quality measure for the Vermont all-payer model was trying to reduce the incidence of COPD, hypertension, and diabetes. So it's a tall order, but it really is a rallying cry for, getting pre-diabetes addressed, getting physical activity in communities, childhood obesity, etc. Smoking cessation efforts being more reliable and getting people's attention about that.
Thanks, Norm. So I think everyone here is, I'm sure, aware that only about 20% of your health is attributed to the care you get in your doctor's office in the hospital. So most of your health and a huge amount of the spending that occurs because of your health occurs outside of your doctor's office or the hospital. And if we're going to be successful in this model, we have to make an impact on that. We have to help people be healthier. And so there's a big focus on social determinants of health. How do we keep people healthier? How do we make sure they have warm, secure housing to stay in? How do we make sure they have food security? How do we make sure they have safe places to exercise, streets to walk on, good employment? And so there's some work going on that. And at a more patient-focused level, we have complex care coordination. So if you're a person who's in the category 3 or 4, those bottom 2 quadrants, the medical practices get extra dollars to basically build a complex care plan around that patient. And one of the areas of focus is, what do the patients want to focus on? That's Camden Card, something you either have learned about here or you will if you haven't heard it yet. So what areas of your life do you want to work on? Better relationships, better housing, less drinking. Norm told me after last night he put that on his Camden Card.
Oh, that's it.
From the Pine. Jealous I wasn't there. And so good work there. So there's dollars flowing into the practices to make a difference there. That's really important. That's a change from the past. We want primary care to increase screening for adverse childhood events, food insecurity, parental depression. Improve coordination of referrals, warm handoffs to make sure that patients are going out to the VNA at appropriate times. The VNA might be able to do a good care plan. They might be able to do med rec or a falls risk assessment that comes back to the primary care office so they can make sure they're coordinated on their plans. And there's a lot of work going on around accountable communities for health. Having your whole community be focused on wellness, making sure people have good jobs and so on. There's a lot of work going on right now about anchor institutions, and I just met with Sally Kraft from Dartmouth, I think it was on Wednesday, to talk about, in most communities, especially in rural areas like Vermont and New Hampshire, very often the hospital is the largest employer, has the biggest resources, has the most dollars, and so how can you use all of that, all those dollars and resources for the good of your community? How can you make sure you're buying local, you're hiring local, you're promoting people, you're using the resource of the hospital to make sure there's good walking paths, transportation, and so on. And I really think this model really helps make your hospital being an anchor institution make a lot of sense. And I've spent a lot of time in the network now talking about that. So with that, I'm going to shift to Dr. Ward.
Okay, thank you very much. So you've, as soon as I flip the slide, you will recognize this slide again as our four-quadrant model, but it's shown again here to try to emphasize a couple of different points. The quadrants are the Johns Hopkins ACG grouper. We take the claims for Medicare, Medicaid, and our commercial lives and put them through Johns Hopkins and determine the very high, the medium, and the healthy risk categories. I think that, you know, my impression of care coordination in the current fee-for-service world, that it's highly fragmented. Many programs are either grant-based or disease-based. You know, people, care coordination nurses know, you know, their set of paperwork. They know they can dig in and help people with very narrow needs. The thing that we have identified is that not only the didactic understanding of what complex care coordination is, to train up these folks who have been siloed into a more general approach is very important. And even just on this slide, probably the most important thing is, at the very least, just setting some guardrails around what the expectations are. So, you know, greater than twice a year, 4 times a year, and monthly. So the practices look at this and say, oh, that's a burden, but at least it's setting some sort of expectation for attacking these folks in an organized way. I will say that we've also invested in a web-based tool as a care coordination communication hub. Also, in the current world, with everybody having different electronic medical records that don't talk to each other, you know, we're left with faxing, telephone calling, and those inefficient ways of communicating. So in our model, people around a complex patient are able to communicate more effectively. In terms of some financing, we had to come up with a construct, and I will say that Sarah Barry in our shop and Vicki Lohner, who could not be with us here today, were very instrumental in this. Vermont has a long history of something called the Vermont Blueprint for Health. So a lot of you know, Vermont's success in this area relate to the fact that a lot of foundational work was done getting primary care into the patient-centered medical home, NCQA certification, almost universally around the state. So that was a huge foundational benefit. And so the so-called community capacity payments are some modest funds to engage the blueprint manager in each of our hospital service areas to help coordinate these efforts. The level 2 funding is basically a per member per month for the top 16%, those quadrant 3 and quadrant 4 patients. It's $15 per member per month, and it is to help those practices mobilize to work with those patients. This is new work for them. They've never really been paid for that. And then the nice thing about the level 3 and the top of the pyramid there is that there is a similar payment to not only the patient-centered medical homes, but also to community entities who may be interacting with these complex patients. So there's a $10 per month, per member per month payment to the entity that the patient has chosen to be their lead care coordinator. It's not obvious that Mrs. Jones, who might see me, is necessarily going to relate to my care coordinator better than she does with the Area Agency on Aging coordinator that she works with. So we're trying to recognize that the patient choice in this is very important. Data. So our philosophy in our data approach is that we want to have this as much in the hands of our provider network as possible. We want OneCare to be a thin layer. We use Care Navigator, we use Health Catalyst as our warehouse that receives the claims information. That's where the risk adjustment processes are acted on. The Vermont Health Information Exchange absorbs clinical information from each of the 14 hospitals and as many practices as are feeding information. I think we're all a little bit disappointed in how vibrant that process has been. It's getting better, but our approach analytically is to, and this is just an example of looking at the an attempt to measure the quality of the data flowing from the health information exchange into our programs. We also have, obviously, apps within this to help with our data collection and producing standard reports. As we're entering risk, the bottom line is that our provider network is going to demand, month to month, as close to real-time monitoring as possible of what their performance against what we're calling the shadow fee-for-service. People are obviously still submitting claims, but they want to know how they would have been paid in the fee-for-service world compared to the money that we're paying them in a fixed payment.
And I'll just add also, they really want some proactive information. So if you know somebody has recently been in the ER or whatever, they got a lab that needs to be acted on. And so having someone in the office that can run those lists and look at what's going on is really critical in this model. And that's a big change from what we've done in the past.
This is going to sound odd, but we've spoken about the fact that the hospitals and their employed physicians are now basically capitated in a fixed payment, convincing people like myself and Steve, who are in the faculty practice plan at the University of Vermont Medical Center, that we are already capitated, that technically speaking we are freed up from the RVU treadmill, getting that message out while we're still in the foot in both canoes situation with fee-for-service and some moderate amount of capitated care is a tough message. So we're working on that. The next slide is basically an attempt to show our attempts at trending over time, over years. These are just examples of Medicare targets. The eye chart in the lower left-hand corner is our version of the ACO 33 from Medicare. And we can show year-to-year progress as far as our percentile rankings. And then the bubble charts on the right show the lower panel is 2014, the upper panel is 2015. The basic theme here is that when we were first starting out, there was a fair amount of distribution, scatter amongst our 10 or 14 communities in the program. And you can see that the efforts to improve quality are getting results at bringing everybody along to try to improve their quality measures.
You want to be in that upper left quadrant, high quality, low cost. Okay, so if you go look back,
you want to be up,
that's where you really want to be. So you can see that in 14, first year, there's some people that are in the lower right quadrant. Not being judgmental, there's a bunch of reasons for that, but really has migrated towards that upper left, which is where you need to be to succeed in this model. High quality, low cost.
So this slide sort of brings it a bit all together, mainly around primary care. So this is what we would call our standard model, where we pay at 12 o'clock, we're paying about $325 per member per month as what's called an administrative payment. This is per attributed life paid to each primary care practice. The $15 per member per month, which could be as high as $25 per member per month if the patient chose the patient-centered medical home as their lead care coordinator. I also didn't mention that there's a $150 one-time creation fee for the shared care plan for these complex patients. So this is the money up here, which is an infusion to primary care. Over here is Care Navigator, the communication pipeline for doing care coordination, hopefully more reliably. Workbench One is the data analytic platform put into the hands of clinicians. I also want to mention that down here at 6 o'clock is the continuation of the blueprint. And the blueprint funding basically is per member per month practice payments to the NCQA certified patient-centered medical home, as well as something called community health team, a shared resource in each community, typically around shared clinicians like diabetes educators, nutritionists, social workers, nurse care coordinators, as well as the SASH program, support and services at home, a pretty effective, innovative Vermont model, basically congregate housing for the most part for the elderly, individuals, support staff in the congregate housing, checking on people frequently, calling in skilled nursing when necessary. But it shouldn't go without saying that the $7.5 million that Medicare was contributing to Vermont's Blueprint program had been through the multi-payer advanced primary care practice program, which ended in the end of 2016. So OneCare has become basically a pass-through mechanism for that $7.5 million of Medicare money to continue to flow. And then over here on the left is obviously the quality collection and quality improvement. The other thing we haven't talked about is that, we were all disappointed for years about never getting a shared savings check, except 1 year for Medicaid. Now that we're in risk, the idea is that we are right at the beginning of the year taking off in the range of 0.5% to 1% of the total spend, reserving it to be paid out 70% to primary care and 30% to hospitals and specialty care, that we want everybody to feel like quality is job one and that there will be a reward for them at the end of the tunnel.
Everyone gets a trophy.
That's right. But it is hospital money, and it's a very interesting model. We have yet to distribute that. We're waiting on the final calculations on our 2017 risk Medicaid program in 2017.
Turning it back to me, but I think Ellen was trying to catch my eye.
There's a number of questions bubbling up. This is great, but I thought this might be a good place to jump in. The most recently on sort of this, talking about these models and how these different programs are fitting together, I think that the audience has some catch up to do. And some of the questions folks are asking is, how do these partnerships make sure that things aren't overlapping? So tomorrow there's going to be this session about transformative partnerships, and the question is, how are you working with organizations like visiting nurses, mental health, housing, substance abuse, et cetera, to make sure things are not duplicative? I gather Robin was chiming in and there are some things in place, but I also want to attach to that some questions about looking at this. It's a little bit overwhelming. There's a payment for everything, and the question is sort of, are we just getting into a mindset where we need to bill individually for every separate intervention? And that feels like we're still in the sort of fee-for-service
There's a
mentality.
second component that's more advanced called CPR, which I hate because I'm an ER doctor, but it's comprehensive payment reform. They named it that, and I was like, why? But anyway, and that is an all-encompassing payment to the practice for all attributed lives on this advanced model. And I will tell you that a lot of primary care practices were very interested in that for exactly that reason. It's much simpler. It's a little more risky. But for a bunch of reasons, we weren't ready to do it everywhere yet because we wanted to see if it worked. And we picked a couple very high-performing practices that really understood the model and were very invested and brought them in first. But I wouldn't be surprised over time, because I agree, there's a lot of moving parts in this, that people will want it to be simpler. In terms of coordinating the care and making sure that people aren't stepping on each other's toes, which I've only heard Dr. Ward say about 1,000 times, there's a lot of work going on that. And I will tell you that when you become the Chief Population Health Officer for a UVM network, all day long I see people coming in wanting money to do the God's work to fix this whole thing. And being smart about how we do it, how we share the different pieces. So there are some dollars flowing to parts of this system, and we're asking them to add to what they're doing. Not just do what you're doing before, add something. And then by doing that, you kind of control who's doing what. So there's dollars flowing to the VNA, there's going to be some dollars flowing to SASH and AgeWell. And then the ask is, show us what's different with that, what are you doing? And I'm meeting with the VNA because we're going to do some extra visits. That's not a complete answer, but a start.
The other aspect, in each of our hospital service areas, which basically are each county, about 14 Vermont counties basically have a hospital, and they're geographically fairly isolated. But the community collaboratives, which were part of the Blueprint work in earlier years and with the help and support of OneCare as well, These are local committee meetings where all of the stakeholder groups get together. In some communities, this had never really happened before, and getting people on board with, gee, you do that, I do that too, who's going to do it? And Care Navigator basically helps to also organize the fact that if two people are interacting with the same person, let's not do it twice. In terms of the payment confusion, I think if we had just come out with, this is the new payment model without some effort to link duties with payment, people get antsy and confused about what that means. So although it sounds complex, it I think is an important step.
And I'll just add to that like tying the $15 to those level 3s and expectations for what they're going to happen, how many times they're going to be seen and so on, that's something that practices can act on, and you can hold them responsible and accountable to that. The CPR practices that were picked are already pretty advanced in their care model, and so I think there's some work to do to have something like that across the state, although I think that's a great goal to work towards.
Set.
Comments, there are several comments bubbling up about some of the social determinants and how the practices do that. If you don't get to that at all during your comments, we can come back to those during questions. But basically the general nature is sort of, how are the resources going to be available for primary care to make those changes, as well as sort of longer term questions about, you have these outcomes, you have these quality metrics that are based on outcomes, and is 5 years long enough to move the needle on some of them? It's kind of coming back to this question about what are the scary outcome measures. But and again, I think we'll have some time for questions. But if you're going to go near there, go ahead and dive in.
Okay. So talking about the legal and regulatory landscape, I see this as a time of tremendous opportunity. If I were to just look around the room, I am guessing that most of you have been told that something that was clinically appropriate or some arrangement that you wanted to make you couldn't make because of fraud and abuse laws, or you might be able to do it for one cohort of patients but not your Medicare patients or not your Medicaid patients. Right now, I'm in this great spot where I don't have to say that to this group of people. As we're trying to make change, what we have is an aligned legal and regulatory landscape, which is not something that I've seen before, and I think it offers tremendous opportunities, and I'll show you how. So the ACO is regulated by the Green Mountain Care Board. There are certification criteria. Our programs are aligned with methods, with measures, and we have this opportunity to waive fraud and abuse laws. And we had that opportunity as part of the federal Next Gen program, and then the state Medicaid agency recognized the benefit of having uniformity, so has also allowed us to use the fraud and abuse waivers for Medicaid patients. So right there, that means that you don't have to separate out patients to do something under the circumstances that I'll describe. But it allows for one care path taking off your decision tree, how are you insured? And I think that that's going to lead to tremendous simplification and some common sense clinical protocols that we can start implementing. So generally, what fraud and abuse laws do is they live and regulate in the fee-for-service world. And in the fee-for-service world, the assumption is anything that induces volume is bad. It doesn't matter if it induces a service that is a lower level of care than something else that would have been used otherwise. It induced volume and it was bad. Anything that, a transaction that has a financial relationship between a referring provider and a provider receiving the referral is bad, and we disincentivize that in the fraud and abuse world under fee-for-service, because the government's presumption is that if I create a service that I have to pay for, then I'm paying for something that otherwise wouldn't have happened. And that doesn't really make for very effective care paths at all. So they're waived because you cannot do value-based payment, you cannot make payment changes, and you can't reduce fragmented and unnecessary care if you don't let providers interact and have arrangements with each other that will benefit the patients. So This is just kind of how I see the world right now. So right now, most of the world is on a full stop for some innovation, and it's not a typo, it's a long light, right? So regulation is not quick to change. So, and living in this boat into canoes, or foot into canoes world, the federal government on an overarching basis is not quickly going to adapt its regulations to value-based payment. So what are you going to do to try to help the government change the regulations so that it is more amenable to cooperation amongst providers, financial relationships amongst providers that benefit patients? So right now, with these fraud and abuse waivers, we're in this testing phase. We're at a yellow light. And basically what the state and federal governments have said is within the context of the Next Generation ACO program, we're going to allow you to create arrangements that would otherwise violate the fraud and abuse laws, but we're going to let you go ahead and do them under a particular set of circumstances. So the government has taken some comfort and safety in the nature of what an accountable care organization is and the requirements that they've put on accountable care organizations that participate in the Next Gen or the MSSP program. So these waivers are available for shared savings programs, and they're available for Next Generation programs. They have to tie to the purposes of the program. So in a shared savings program, the purposes of the program are not as broad as they are in a Next Generation risk-assuming program, but there's room to use the waivers in both sets of circumstances. I'm going to focus on Next Gen because that's where we're focused and it's a little bit broader. But an ACO is an organization that has 75% of its board representing providers that participate in the ACO. That's one comfort that the government takes. The ACO has to have a transparent governing process, and that's another comfort that the federal government takes in allowing these fraud and abuse waivers to be used by ACOs. There are also transparency requirements for the actual arrangements that are taking advantage of the waiver. And most importantly, the board of the ACO needs to act as a gatekeeper. So you need to create an arrangement where the board can make a determination that it's reasonably related to ACO activities. And ACO activities are pretty much anything that you do under the Next Generation arrangement intended to achieve the goals of Next Generation. I have a hard time envisioning something that is a legitimate enterprise that would not be able to take advantage of the fraud and abuse waivers. Clearly, you can't say, I'm going to give you $100 for every referral. That's not legitimate. But when you start to think about changing care patterns in ways that you wouldn't otherwise be able to do, to refer to someone with whom you have a financial relationship without worrying about anti-kickback, or to give things to your patients to help them manage conditions that you wouldn't otherwise be able to do. Those are the kinds of uses that we see. So the hope is that if we act responsibly in this testing phase, then we can set the stage for the next goal state, which would be to have a green light to go ahead and make arrangements that actually align with how you're paying and organizing yourselves. So this is an example of a waiver program that is still in development. I had hoped to get it in front of the OneCare board before this presentation, but it hasn't been able to. But essentially, here we start off with an idea, and part of the input, which I would love, is where do we get our ideas from? I have conversations with other attorneys all the time where they say to me, well, we wanted to make this particular arrangement and we couldn't. And then I can say, wait a minute, maybe you can. So the very first idea, I'm going to jump a little bit ahead. The very first idea that we're trying out or pushing through the system is one where another attorney called me and said that they had a hospital who was looking at using home health visits for joint replacement candidates and doing the home visit ahead of the actual procedure. So they were looking at people who were scoring on a borderline of going home or going to a skilled nursing facility. There is an Office of Inspector General advisory opinion out there that says that a home health agency cannot go and do that visit pre-op because it would incentivize the use of home health services that the Medicare or Medicaid agency would have to pay for. And in looking at that decision, they didn't say, but what's the alternative? We're going to send this person to a skilled nursing facility, instead pay more, have a worse quality result, and have a less happy patient who's going to heal more slowly. That balancing's not in there because it's just you incentivized a service and we don't like it. So when we were starting to talk about this, the first question was, well, could I have them do phone interactions or phone interviews instead? And as we worked it through, we said, look, under the right circumstances, you can send the VNA to the home, get the home adapted pre-operatively, and get that person home instead of to a skilled nursing facility. So that's how this thinking really started, and that's one of the ideas that we had. But I'd like to think of ways for us to be more intentional about procuring the ideas that we can try to pursue for this. But once the idea comes, it would go to council and the chief medical officer and compliance as well, basically say, is it a feasible idea? Is it reasonably related to ACO activities? So ACO activities include coordinating care, they include managing risk, they include promoting access to healthcare information for attributed lives, promoting adherence to treatment regimes by attributed lives. So there are some ACO activities that are only going to relate to the lives that are actually attributed to you, but there are a panoply of them that can actually relate to all of your patients. The ones that are generally going to be limited to your attributed lives are when you give something to those patients. So if you want to give the patients a smartphone with apps that are appropriate for their disease state that can help them manage that, we could work that into a fraud and abuse waiver, but not for you to give it to every Medicare beneficiary, but the attributed lives. So those are some of the limitations. So the initial flow would say, hey, is this something that's worth us investigating further? Should we look at it? Could it possibly work? And if it's a no on either one of those fronts, then you would come to a stop. If it's a yes, then you start to move further down to the program design. So when we talk about this home health agency visit, then you start to want to think about, okay, how many joint replacements are in the network? What's the size of the universe of patients that we might want to include in this initial program design? Do we want to look in only one health service area? Do we want to look at additional health services areas? And what's really important, and which is, I didn't think like this before I came to the program, and I don't know how many other council are actually thinking about this, but how are we going to measure it? How are we going to capture the data on it that will provide an evidence-based support for moving toward that green light? And that's a really important aspect. One, do you want to try to help the policy move forward, but also the ACO itself is investing all kinds of effort and transformation in a care delivery system into applying a fraud and abuse waiver, and you want to make sure that you're doing it as effectively as you possibly can. So maybe there are some areas that are less amenable to this. So when you get into, that's the design, and the idea is that it would go through the Population Health Strategy Committee to kind of put a fine tune on it. You wind up with your program. It needs to go to the board for a determination of whether it's reasonably related to ACO activities. The idea is that there would be a chart and a metric for the board, and the board would understand it. If the board says yes, you can go ahead. There's a requirement that you publish on the ACO's website a description of the arrangement and the parties to the arrangement. So that's part of that transparency. The idea is you're not going to go and engage in risky or inappropriate behavior if it needs to be laid out in the public eye. And the other benefit of that is that it's laid out in the public eye. And if it's a good idea, other people can pursue it as well, and that would just build more momentum for some policy changes that they're absolutely necessary in order to make this transition. So some ideas for potential waiver uses, and there's another area where anybody who has any ideas, it would be great. But embedding services. So Norm talked about this, but there's a program to embed mental health support services in senior living situations. That one was kind of close to the line, and what we did was we allowed for a choice of different providers, so we didn't actually invoke the waiver for that. But if we wanted to have a preferred provider relationship with someone who we thought was doing that particularly well, you could go ahead and use a waiver and embed those services, or in any other kind of a situation, embedding other kinds of services in senior living communities seems to be a pretty good strategy. Providing in-kind items to patients, we can drive them places, we can help them with grocery shopping. There's a lot, I think, of opportunity and social determinants for this. IT coordination, normally you cannot give your electronic medical record to another provider. It looks like an anti-kickback issue. There's a lot of room for coordinating IT infrastructure by using these waivers. And that would be a tremendous service, I think. Unit-based performance, right? As part of our project, we set up an accountable care unit at the University of Vermont Medical Center. Maybe you could incentivize performance on inpatient units by bonuses or other kinds of opportunities. And moving utilization to a lower level of care. And I'm going to ask Norm if he might speak a little bit about IV antibiotic therapy at home, which was a goal to potentially be able to use the waivers for.
Well, I don't know how many of you out there are doing the standard Medicare Next Gen model with the 3 waivers. What we've learned is that the majority of Next Gen participants are doing the so-called 3-day nursing home waiver, where you don't have to spend 3 midnights in the hospital. Many fewer people are actually doing the billing for telemedicine with the patient at home and the post-discharge home visit. But as part of the Vermont all-payer model, the potential ability to create additional benefit waivers in Vermont. So one of the favorites among my colleagues is around the fact that, you know, if you're a Medicare patient with a serious infection, many people often either get stuck in the hospital if it's an expensive drug, because the nursing homes don't want to take them because that is going to come out of their per diem and they can't afford it. Or they may go home, which is then going to mean that the patient gets transported every day to an infusion center or an ER to get an infusion of medication. So wouldn't it be nice if home infusion therapy for long-term antibiotics in Medicare patients was allowable? So this is just one of the ideas.
So as Norm's talking, that brings up a difference in waivers. And so basically there are, the waivers that I'm talking about are fraud and abuse laws, and then there are benefit waivers. But the great thing for me is if Norm doesn't get the benefit waiver, I could give him a fraud and abuse waiver to use, because if it's not covered, you would be giving a Medicare beneficiary something of value to induce them to utilize your services. So it's a non-covered service, is something of value that you wouldn't otherwise be able to give. But if the board were to make a determination that paying for the therapy to be at home, either from funded by a hospital fixed payment because it'll ultimately lower the claims that or lower their costs, or I'm not sure how we would pay for it. We would have to figure that out. But it could be done using a fraud and abuse waiver, even if the benefit waiver isn't allowable. Another thing about these fraud and abuse waivers, which is excellent, is you don't have to ask the federal government or the government to use them. You just declare that you're using them. And that's why the board, being the gatekeeper, is really helpful. And it also allows a lot more control about how it's done within the ACO itself. So you don't have a regulator wanting data to prove its own regulatory issues or theses. So for example, in all-payer model, I think that there's a lot of data collection or a lot of information that is going back to the federal government, because the federal government and the state government have a vested interest in having some kind of evidentiary basis to evaluate this experiment. But we can do a lot within the experiment on a micro level that doesn't need to be vetted with the regulators. And I think that that's a big flexibility that's very, very helpful, and it allows us to be more nimble in trying things and seeing what works. And maybe also because it's within the ACO's control, if it's not working, you can pull the plug a lot faster than if you have some regulatory oversight. So if things are going wrong, you can stop. Or if it's not being beneficial, you can stop, or you can tweak and you can readjust. So it's a very malleable format, and it's a very adjustable format. So a lot of the things that we've been talking about right now are what kinds of alignments we have on a macro level. We've got these policy alignments, we've got payment alignments, but now the opportunity for the ACO is, since we've been operating since 2012 in this model and the training wheels are off, what changes are we going to make on a micro level to really make our risk-based or risk assumption work for us? And Steve is going to.
So this slide basically shows, there's 3 different sources of money coming into the ACO, but that's not completely correct. I already told you there's a 4th source. The hospitals are diverting operating dollars into the model. And for this model to succeed over 5 years, the hospital's true operating costs need to go down. We need to have hospitals use less resources. And so I was telling you earlier that Dr. Ward and I have spent significant time talking to providers across the medical group and in the state, and everywhere you go, as soon as you would introduce the providers, always say the same thing. This doesn't work in an RVU model. This doesn't work when I still have to see patients. And we heard from a ENT doctor in the state of Vermont, and what he told us, which makes good sense, he'll get a call from a primary care doc. Primary care doc will tell him about some child who has recurrent ear infections. And the ENT doc said, I could easily manage this on the phone with 5 minutes of information. But when that child comes to my office, that's the easiest case I see all day. It reimburses really well. They always have insurance. And I need that level 4 service to hit my RVU target so I get my salary. So why would I ever right now just give the advice on the phone? So we have to, number one, help our providers get away from an RVU model. And secondly, we have to incent our providers to have our hospitals be more efficient. And so Linda and I have started spending some time now talking about, with a hospital on a fixed budget, if really 80% of lives in Vermont are under capitation, margins of the hospital in that model come off what you didn't spend, not on doing more, not the one extra back surgery or hand surgery. It's really on how did you operate more efficiently and kept your spending under your capitation. In that model, if you could incent physicians with gain sharing to decrease length of stay, to have no readmissions, to have people not show up in the ER, go to their office that night, to keep down infection rates. I mean, imagine a model where you incent your CT surgeons to get people out in 3 days, to have no sternal wound infections, to have no ED bounce backs for CHF, and they would got some of that gain share. That's, in my view, a really strong model for making this work. And so we started having a discussion, and some of this is a little pie in the sky, but if OneCare earned share savings this year, as it was getting distributed back to the hospitals, could the UVM Health Network share those dollars back to the docs around very specific things that for the hospital presidents are cost drivers, length of stay and readmissions. And so this model, the ACO model, OneCare, starts taking us in that direction. And I pretty strongly believe, and I think Norm agrees with me, that if we don't get our providers off of the RVU wheel, and we don't figure out a way to incent them to be as efficient as possible, meaning answer the phone, tell the pediatrician how to keep the kid there, see the extra patient on Saturday morning instead of sending to the ED where they're likely to get admitted, we'll have trouble having this model succeed. And so I think that's our last slide.
Yeah.
Thank you.
Thank you.